in AML.
Thank you very much, and this was a fantastic session. It's amazing and great credit to Dr. Pamaraju, Dr. Marconi, and everybody that we have two sessions in BPDCN, a disease that 10 years ago nobody really knew the name of. So I think this is wonderful and showing the progress in identifying new targets and bringing new drugs forward. I think this is very important in what's going to happen with immunotherapy in acute myeloid leukemia. You know, if you look historically, not really historically, in the last 5 to 10 years, the major paradigm shifts when we have made true breakthroughs in heme malignancies have come from immunotherapy, lymphoma, multiple myeloma, ALL, right? It's all been CAR-T, bispecific antibodies, and ADC-based. And in AML, I think we're behind, but I don't think that means we're not going to be there. We saw the same with targeted therapies. It took us about 10 years after melanoma, lung cancer, colon cancer to identify and implement, and that's just because AML is very difficult. Multiclonal tumor microenvironment is extremely aberrant, and many of the immune cells themselves tend to carry mutations and have functional abnormalities as they come from the bone marrow. But these are the kind of directions for immunotherapy. ADCs, I'm not going to talk about. You already heard a lot about CD123, CD33, of course, is the other traditional target and the only quote-unquote immunotherapy, but it's really a cytotoxic therapy being delivered using an antigen target with gemtuzumab ozogamicin, and there are other targets in development. But when we're thinking about immunotherapy, especially from the solid tumor and other heme malignancies, I think we're really thinking about how to harness the body's own immune system, whether this is T cell, which is the one that's been done the most frequently with immune checkpoints, bispecifics, CAR-Ts, or now even more and more towards the innate immune system, which I think was a little bit under-recognized, but now is coming to the forefront with NK cell therapies, as well as macrophage and dendritic cell-based therapies. And I think in myeloid diseases, for many reasons that I'll kind of talk about, I think this is the more important component to harness and the one that is not as hypofunctional or affected by the disease in the bone marrow. So historically, just a little bit of a background for the junior faculty, fellows, others, the T-cell-based immunotherapy is what has really been used in solid tumor. And if you look at this, what really happens is in general you have a foreign antigen tumor. This causes stimulation of a T-cell response. These T-cells then go back to the lymphoid organs and stimulate dendritic cells, APCs, and then result in more T-cells. And this is kind of a virtuous cycle in a way, not a vicious cycle, because it's a good cycle that helps to get more T cells to attack the foreign antigen, which in this case would be the tumor cell or the leukemia. But this is only kind of part of the puzzle. And, as had been done in many solid tumors and with Hodgkin's lymphoma, we also evaluated in multiple trials, in a set of almost 10 clinical trials that were done at MD Anderson between 2011 and 2016, many different immune checkpoints, PD-1, PD-L1, CTLA-4, combinations of those in different myeloid diseases, AML, MDS, myelofibrosis, and even CLL. And unfortunately, the summary of all those efforts was we did not find a clear benefit of immune checkpoints, especially PD-1, which is the one that has done so many breakthroughs in solid tumors and lymphoma. We do see that in some subsets, people who have extramedullary disease, post-transplant with a good donor chimerism, and early salvage. And this is a theme now that you hear every talk in ALL, where early salvage, low-burden disease. This is where immunotherapies work best, even the CAR-Ts in ALL. That's where they're curative. And here we did see that there was a sign of improvement because probably the immune system had not been completely deranged by progressive AML in the bone marrow or by therapies like purine analogs, which once you give them often will wipe out T cells. We use them for conditioning. But in the end, we don't think that the traditional immune checkpoints are going to have much of a future. But during that study, we did a lot of additional correlative work, and here you see some of those results. So what was interesting is that there may be a way to identify AML patients that could benefit from T-cell harnessing therapies, whether these are PD-1 or maybe moving along to bispecifics or even CAR-Ts or cellular T-cell based therapies. So we worked with a group called Isoplexis that does functional assessment of T-cell cytokine production. They do a single-cell cytokine analysis of 32 to 36 cytokines, and they're able to give you what we call a polyfunctional strength index. Now, I think this is very important because historically, a lot of studies just look at the number of T cells, and even though there may look like numerically there are T cells in the bone marrow tumor microenvironment, we now know that many of these T cells carry the same AML mutations and are dysfunctional, and also the tumor microenvironment may be impacting them. So functionally, we may be able to identify, for example, here you see in those who had responded, when we went back and looked at their pre-treatment AZA PD-1 samples, you can clearly see they had much higher and much more diverse Th1 cytokines, suggesting we could have potentially used this as a biomarker going forward. Also, Dr. Abbas, who's a fellow, now joined us as a junior faculty, is doing outstanding work with longitudinal single-cell and site sequencing, RNA sequencing-based approaches. And what he was able to show, looking at a population of patients on AZA-NIVO, few responders, few non-responders, was that among responders, there was a very powerful and distinct expansion of T-cell receptor clones and new T-cell receptor clones that was not seen among non-responders. Now, what we don't know is this a function of response? Are you skewing your immune system favorably as a subset of response, and hence you get new T-cell receptor clones and an immune system is resetting to be able to fight against the leukemia? Or actually, is this directly through the drugs? And so that's some work we're doing now. But more and more over the last 4 or 5 years, after these efforts using PD-1, PD-L1, others didn't pan out as we had hoped, there has been recognition of the innate immune system. The innate immune system includes components like macrophages, NK cells, dendritic cells, and in fact, this is the final effector population. So when you look at the death of the tumor cells, it is actually often caused by macrophages that will come and phagocytize the cells. And so now there's more efforts to see if these could be used directly, harnessed to generate anti-tumor responses. Now, this is where probably we need to look at unique ways to target mutations like TP53. This is a review we just published actually a couple of weeks ago for those who are junior faculty. This will be a very useful read. We talk about what the current status of TP53. TP53 remains difficult. We don't have a solution, but the fact that there's so much research and so much discussion and so many trials and efforts is usually what culminates in success. And compared to 5 years ago, I can distinctly say that there's much more effort in TP53. But just to highlight, you see there are so many different components at play. It's not a simple mutation. There's also a lot of effects on the Tregs, the myeloid suppressor cells, macrophages. And then if you look at the trials, I'm not going to go through the list, but the bottom line is the response rates are dismal, 40%, 45%, whether it's cytotoxic chemo, HMA alone, HMA-VEN, and survival historically has been 5 to 7 months with whatever approach we use. Of course, there are efforts with ongoing drugs, CD47, APR, which we hope will bring this forward in the near future. So just to highlight with HMA-VEN, this I think was a disappointing story for all of us. We all were hoping with Dr. DiNardo's work, initially response rate looked good in TP53, and we thought this could pan out to at least some improvement in survival. I think it's unrealistic to hope for a home run curative outcome, but even if we can get a few months in TP53, get some improvement, this could be a stepping stone to further success. But I think at this point now, with 3 different analyses of HMA-VEN in TP53 mutated AML from the phase 1b study, from the DAC-10 venetoclax study of MD Anderson, and from the recent Viale TP53 subset publication, I think most of us will agree that there is really no improvement. Yes, maybe there's a young patient, you can get them into a marrow remission, clearance into transplant, have some hope, but in the end, the survival is 5 to 7 months. And so we're moving to other approaches. There are 2 that were really kind of exciting, and we were hoping both would work out. Unfortunately, the APR, which was the TP53 remodeling, but also now we know had other activities like ferroptosis, did not pan out in the randomized study, even though there was a CR improvement, 33 versus 22%, it did not meet the endpoint, and so we don't know where that will go. But again, here, immunotherapy is what we're hopeful and banking on. The CD47, has had very elegant, high-impact preclinical analyses and work done by Ravi Majeri, Irv Wiseman, and Stanford group. They showed that it was expressed on AML, expression was associated with outcome that was negative, and that also that this worked very similar to a immune checkpoint that you're used to from T-cell. Basically, CD47 SERP alpha interaction resulted in suppression of macrophage activity, and by blocking this interaction, you remove this suppression and the macrophages were unleashed, so to say, to fight against the tumor cells. And this has led to multiple studies, in fact, 3 ongoing frontline phase 3 studies. So a very aggressive development plan here by Gilead, who acquired the 47. And the MDS study I'm not going to talk about, but that has been completed actually. I know many sites in Europe and Italy were heavily participating, and we're hoping to see those data in the very near future. But in AML also there are efforts combining both AZA with CD47 and AZA venetoclax with CD47. This was the most updated data The response rate is about 49% with a true CR rate of about 33%, duration of response about 9 months. So it looks marginally better than what we see with HMA-VEN, especially duration of response, but again, it's not going to be a home run. So hopefully if the study is positive, we get some incremental benefit, then we can move this to the next stage and try to incorporate other therapies into this setting. Here again, as Dr. Pemaraju very nicely said, and Dr. Denaro and me again said, transplant is, in fact, very, very much, in fact, more so today a part of the treatment paradigm. When you talk about total therapy approaches, as myeloma has done, this is kind of the approach I think we need to take for FLT3, which we're already doing, but for TP53 as well, where you get a remission, ideally with therapy that does not cause severe myelosuppression, sepsis, and death. And remember, TP53, not only is it resistant to therapy, you also get more potent myelosuppression and severe infection. So hopefully therapies such as azacitidine-47 will achieve a smooth remission, at least get the blast down below 5%. Hoping for MRD is really unrealistic. It's not seen in 10% or less. So usually our approach is, as you get the blast below 5%, we move to stem cell transplant. And again, small numbers, but that seems to be an approach that could work in this multi-center AZA-MAGRO study. That is where you're seeing 2-year survivals in these patients. So we have a large program now at MD Anderson, Dr. Kadia and our group, and we're trying to move all these TP53 patients within 2 cycles, once they're less than 5% blast, regardless of MRD, to transplant. We know that if they're MRD negative, they'll do better, but we know that we won't get 90% of them to MRD negative, so they will never get a transplant, and at least getting a transplant probably gives you a chance of long-term survival. Now, looking at other ways, this is a triplet that we're pioneering just with IDH and CD123, venetoclax, others, and the early data looks quite encouraging, especially the CR rate. I think that's the only way we can differentiate from AZA-VEN doublet. CR/CRi is already 70-80%, but a CR rate has been about 35-40%. So if a true CR rate is maintained at 55-60% or greater, I think that would be a good sign. This will be updated at the ASH meeting. The nice thing with this triplet is really we don't see any additive myelosuppression. The count recovery has been very good, 28 days, unlike with the FLT3 and others, where of course we have to make many more adjustments. Anemia is seen, all of you know there was a hold, and now the hold is off. This is like any other new drug. You have to learn about it. Menin inhibitors, differentiation, venetoclax, tumor lysis. In our experience with cause awareness, monitoring, transfusion, this has not been prohibited. We've actually not seen any severe issues or deaths with anemia. And then there are 2 phase 3 studies ongoing, as I mentioned, in AML. I think many of those sites in Italy also are enrolling to this. And of course, the big question is aza-magrolimab going to be the same, or will aza-venetoclax-magrolimab show some benefit? Based on the CR rates that we're seeing at Anderson, where we participated and led both of these studies, we think that the triplet may add an additional CR benefit, and Dr. Konopleva may speak about this, where her preclinical work actually does show that the 3 drugs may have unique synergy beyond just either doublet for stimulating phagocytosis. Many CD47 antibodies are in development. We don't have much clinical data, which is why I'm not showing them, but ALX, lemzoparlimab, TTI, and even bispecifics are being developed. The bispecific approach theoretically sounds very interesting because here you can leverage both the adaptive and the innate immune systems to get a kind of a double punch. Whether this will pan out in clinic, we have to see. 2 of the bispecifics are moving into clinical trial. And then lastly, in the last couple of minutes, cellular therapies. So unfortunately, we don't have that much to talk about. Hopefully 5 years from now, we can give complete session on cellular therapy like ALL and lymphoma are doing. But today, we don't have great successes yet in cellular therapy, not for a lack of effort. Many trials are starting and efforts are ongoing. CLL1 is probably one of the targets that looks most attractive when you look at all the publications showing the more specific expression. CLL1 seems to have less expression on endothelium, liver, hepatic tissue, normal hematopoietic stem progenitor cell. But again, when you look at this, this is a review we had put together. These are all single-digit CAR Ts, and many of them stopped because of either toxicity before efficacy or very limited efficacy, and companies decided to move on to lymphoid diseases. So hopefully we will see a shift in this in the near future. There is a CLL1 CAR T from China that's shown some very promising data in relapsed pediatric AML, where they had 9 out of 12 people achieve remission, majority of them MRD negative. We are working with this company, hopefully can bring this CAR T for adults in AML in the near future, and updated data is pending. And then lastly, NK cells, I think is kind of, we're scratching the surface here of what the future of immunotherapy could be. Dr. Kaylee Rizvani in our group has published a lot of elegant NK cell work in lymphoid malignancies. And the big advantage here is you can produce these often from iPSC or from haplodonors, and you can have stocks of NK cells just like you would give a CD123-33 antibody, give it right away to the patient, so you don't have the 2-3 week or 4 week period that you need for T cell development. And one of the NK cells we're working with, FT538, is showing some very early interesting data, especially in low burden and MRD setting, where you're able to give high volume, 2 to 3 billion NK cells weekly, up to 6 doses, and we're seeing MRD clearance in some subset of patients. And of course, the nice thing with NK cell is you see no ICANS, no neurotoxicity, no significant CRS. So not even grade 1, 2, actually we just don't see any. So that gives you an ability to do a lot of manipulations, further strengthen them. Armored NK cells are coming along, and also to combine them with other therapies, which is more difficult to do with CAR Ts. So look out for this space. I think you'll see more in the near future. And then lastly, it's interesting, venetoclax is a drug that seems to be really like the immune checkpoint of heme malignancies. This works in combination with everything, and including with NK cells. This was data from Tony Landai, where he showed that combination of NK cell with venetoclax seems to be quite synergistic, reduces both the apoptotic threshold, and also seems to enhance the NK cell activity. So this may be something we can take forward in clinic. And then the last slide, I think the key is, and I don't know why it's taken so long, and of course I think a lot of us are trying to push it this way, is we need to really focus immunotherapy in low burden disease. Even in diseases that are much more immune sensitive, like ALL, like myeloma, they have come to this realization that CAR Ts really work best in first salvage low burden disease. And in AML, where it's already not immunosensitive, I think that is the only area we should really test a lot of these immunotherapies. And a lot of those trials finally are moving in that direction, the bispecifics, the NK cells, and hopefully the CAR Ts. And I think that is where we will hopefully start seeing successes in the near future. So I will stop there. Thank you very much.